Hi, this is Dr. Janikaram from India, and we are going to start ENT Today classroom. And the first topic of discussion would be how to read a CT scan basics. This is part 1. Basic steps in reading a CT scan paranasal sinuses. Point 1 is always read the CT scan from the first cut. Point 2, read the CT scan cut by cut. Do not jump from one cut to cut 5 like that. So I have seen several residents going to first, then 6th, then 7th. Never do that. Point number 3, read the CT scan 2 times from above downwards. First time is for anatomy, second is for pathology and planning surgery. Point number 4, see the window setting in the CT, bone window or soft tissue window. Usually bone window settings are the best for FES surgery. Point number 5, when you write a request for a CT to the radiologist, write in full. CT scan paranasal sinuses coronal cuts, bones window setting, 1 millimeter cut. Other cuts you might request depending upon the disease, with or without contrast. So this is what you will have to write. But you should mention specifically you want a coronal cut, bone window setting, 1 millimeter cuts, etc. etc. The most important of all, never ever operate without a CT scan just because he can't afford it. You will land up in the court of law. There is no role for screening CT. We will start the part 1 of reading CT scans. We will have several classes on this topic, and this is the foundation on which you're going to build up. The right way to start is, as a PG, just tell this is a CT scan paranasal sinuses coronal axillosagittal cut, bone window setting spaced at 1 millimeter slice thickness or 2 millimeters, etc. Showing when you continue reading the scan, never start with reading the disease. This is the commonest mistake we have seen among residents and PGs. So what they do, the wrong way to start, this scan shows maxillary sinusitis, frontal mucosal thickening, etc. etc. This is exactly the wrong way to start. So what's the right way to start? So read from the first cut and read only the anatomy. Sometimes you may wade away, never do that. The right way is to start from the gantry view, which shows then the first cut, the second cut, and so on. Now, what does the gantry view show? Is it useful? Yes, it does. Now let's start reading the scan. Now this is a CT scan, paranasal sinuses, coronal cuts, bone window setting, 1 millimeter slice thickness, the gantry view showing. The gantry view gives 2 facts. One, the positioning of the patient, and second is the slice thickness. So sometimes you might space the sphenoid more, 3-4 millimeters apart, and the frontal might be 1 or 2 millimeters, so you have to specify. The first cut showing NB, the nasal bones, NS, the nasal septum, and the alar cartilage. So make it a point to read from first cut and read all the anatomical findings. Now the second cut showing the FS, the frontal sinus, the nasal septum. You can look at the nasal body here, and this is a very important cut because you can see on the left side marked NFB, the nasofrontal beak. This is the frontal sinus. So where does the frontal sinus transit into the frontal recess? It is called the T sign or the M sign. If there is a continuity of bone between the lamina papyracea and the perpendicular plate of ethmoid as seen on the left side, then it is a frontal sinus. On the right side, there is no continuity of bone between the lamina papyracea and the perpendicular plate of ethmoid, and so that's the frontal recess. We are going to operate on the frontal recess, not the sinus. You can see the ANC, the anti-Agenasi cell, maxillary sinus, the NLD, and this cut again shows the FRS, the frontal recess on the right side, and the left side showing the frontal sinus. The ANC is the Agenasi, ION, the infraorbital nerve, MS is the maxillary sinus, the maxillary crest MC, and the nasal septum. The NLD is seen on the left side. So these are all the points we have to pick up. Do not read the disease now. Even though you can see some disease there, do not read it now. Now this is a very, very important cut you'll have to read. The PU, the Uncinate process, has to be read from its inferior attachment, and you can see from the inferior terminal it goes upwards and then it ends on the left side in the lamina papyracea. That means recessus terminalis on the left side. That means that the frontal drains medially. On the right side, you are not able to see the complete uncinate, but the horizontal part only is seen attaching itself to the middle turbinate. So here you have to trace the uncinate process from below upwards. This is again a very important cut showing BE, the bulla et modalis, the suprabullar recess, because this has to be exposed. In many cases we trace it backwards towards the frontal recess. So the PU is the uncinate process and MOS is the natural ostium of the maxillary sinus and the crista galli. Now here it's a very important cut. You have to read it very carefully because the AEA, anterior ethmoidal artery, is seen on the supromedial part of the orbit, and it produces a nipple like appearance called the Kennedy's nipple. So this is produced due to the elongation of the superior oblique muscle. The anterior ethmoidal artery runs between the superior oblique muscle and the medial rectus. Another important thing you see here is the SB. This is where you read the type of Quiros classification. Do not read it in anterior or posterior cut. Here you have three types of Quiros classification. Now you draw an imaginary line onto the superior wall of the orbit, and from there a vertical line downwards. If you have a height of 1 to 3, it's Quiros 1. 4 to 7 is Quiros 2, 8 to 17 is Quiros 3. Here you have a Quiros 2 type of classification. You can see the medial rectus marked here. This is again a very important finding. You can see that the anterior ethmoidal artery is dehiscent here because there is a supraorbital pneumatization. So if there is a supraorbital pneumatization, the anterior ethmoidal artery is dehiscent. So we might injure it during surgery. The still posterior cut, you can see that the middle turbinate on the right side ends in the lamina papyracea, and that's the basal lamella. And so you can see behind it will be the posterior ethmoid. The superior turbinate is seen here. These cells become larger, more rectangular, and they are not rounded. Here you can see that the skull base, posterior skull base, is thicker, it slopes down, and you can see the rectangular cells there, the PE, the posterior ethmoid, and you can see also the infraorbital fissure on IOF marked on the right side, and the middle turbinate, the horizontal part of the middle turbinate. This is the third part of the middle turbinate, you can see very clearly. So these are the things you have to look for. The next cut showing the natural sphenoid orifice, the ostium, SPOS, and you can see the right dominant sphenoid. Always look at the sphenoid sinus pneumatization in every CT scan if you want to do skull base surgery. That's a planum sphenoidale marked PS and the OX orbital apex. Even though you find some disease, never look at it right now. This is a scan showing a lot of findings, the ACP, the anterior clinoid process. If you find any horizontal partitions in the sphenoid sinus, it is an Onodi cell. So if you have an Onodi, always look for dehiscent optic nerves. SIS is the intersphenoidal septum. You have two canals in the lateral aspect of the sphenoid sinus. The VC is the Vidian canal, and foramen rotundum is lateral and superior. You can see the rostrum of the sphenoid bone, the lateral and the medial pterygoid plates marked LTP and MTP, and the nasopharynx. Now this is the posterior most cut you have to look for, the right dominant sphenoid SPH, and you can look at the foramen ovale FO and the nasopharynx. If you see some bubbles like this is a CT scan in a cadaver. So you should always think about it. So that's how you read the CT scan for anatomy. Now, anatomy of the frontal cells. We are now going to discuss only the anterior group of cells. We will be discussing frontal recess anatomy in very great detail in a particular section of reading CT scans. Now let's see what are the anterior group of cells. Frederick Kuhn has classified it into 4 types: type 1, 2, 3 and 4. Type 1 cell is a cell above the Aganasi, below the nasofrontal beak. It's a single cell. Type 2, it's more than one cell, 2 or 3 cells below the nasofrontal beak above the Aganasi. Type 3 is a single cell extending to the frontal sinus above the nasofrontal beak, and type 4 is an isolated cell inside the frontal sinus, or according to P.J. Ormond's classification, the vertical height of that cell inside the frontal sinus is more than 50% of the height of the frontal sinus. Then it comes under the classification of type 4 Kuhn classification. Remember that all anterior group of cells push the frontal drainage pathway posteriorly, medially or laterally. Here is an example of the ANC Aganasi cell, and the CB, concha bullosa, in the middle turbinate. This is a classical type 1 cell. You can see that the cell is below the nasofrontal beak on the right side, and it's a bipartite Agassi cell. So this is a classical type 1 cell. In this cell, you can see there are two cells in the right side above the Agassi, classifying it into the type 2 cell. Here you can see a classical example on both sides of type 3 cells. So you can see a type 3 cell and also type 1 cell on the left side, and here you can see very clearly a type 4 cell, which is an isolated cell in the frontal sinus. Now you should also look for certain other anatomical findings. Let's start reading a CT scan together now. Let's practice this exercise together. Now this is a gantry view of a patient of paranasal sinuses CT scan, and showing the first cut, the frontal sinus on both sides, the ascending process of the maxilla, the cartilaginous portion of the nasal septum deviated to the left side. You can see the septal body is very prominent on the right side, and you can see the frontal sinuses and the nasal bone, the frontal nasal suture there. This cut shows the frontal sinus very clearly, the superior deviation of the nasal septum to the left side, and the septal body prominent on the right side. You can see that the ascending process of the maxilla is seen very clearly, and the next cut showing the septal body prominent. So we might have to do a septal correction if we want to do a fess on the left side. So this is why I said you should read the anatomy. So here you can see an interfrontal cell appearing. The frontal sinus still remains, it's not the frontal recess. You can see also a cell there on the left side. It could be a type 3 cell because it is above the nasofrontal beak. So here you can see on the left side very clearly that could be a type 3 cell, and the Agassi cell appearing on the right side. So you can see the Agassi on the right side. The left side you can see a median type 3 cell. You can see the middle turbinate has started appearing, and you can see in this cut that the uncinate process has started appearing there, and it is going and ending towards the lamina papyracea on the right side, the maxillary sinus, the nasolacrimal duct on both sides, and you can see the frontal recess has started appearing. It's not the frontal sinus because the M sign is missing. This is the natural ostium of the maxillary sinus. On the left side you can see the uncinate process very clearly going towards the lamina papyracea, and that's marked in the white dots, and the inferior and the middle turbinates. And here you can see the nipple sign on the right side produced due to the superior oblique muscle, and you have a small supraorbital pneumatization, so the anterior ethmoidal artery might be dehiscent. It's a Kiros 2. Here you have to read the Kiros type, and also you can see the bulla ethmoidalis, and here you can see the basal lamella very clearly on the right side, superior oblique and the medial rectus, the anterior ethmoidal artery, and as we go behind you can see the posterior ethmoid, the superior turbinate appearing there. And this is how your mind should start reading a CT scan. So you can see here the posterior ethmoidal cells, and also the horizontal portion of the middle turbinate, the inferior turbinate there, the maxillary sinuses, the orbital apex, the inferior orbital fissure on both sides. So here you are tempted to read the left posterior ethmoid as sinusitis. Never do that. You can see the superior turbinate, posterior ethmoids on both sides. The superior turbinate is seen and the orbital apex is seen. Never read sinusitis right now because you will deviate from anatomy. Finish off the anatomy. You can see the posterior skull base, and then you go to the next cut. Never see the anatomy pathology first. Here you can see the Vidian canal, the foramen rotundum, the sphenoid sinuses on both sides, the anterior clinoid process appearing on both sides, and here is the sphenoid sinus. You can see the intersphenoidal septae there, and you can see on the sphenoid sinus and the nasopharynx the median lateral pterygoid plates, and you can also see a lesion there, but don't read it right now. This is for anatomy. Again, the class is emphasizing on reading the anatomy alone first. So that is why we put up the scan. Now you go to the pathology and say that you have a soft tissue mass in the posterior ethmoid on the left side, and then I will plan surgery on the left posterior ethmoid, and you can see the lesion very clearly there inside the sphenoid, and this is a soft tissue mass in the sphenoid sinus on the left side. This is actually a meningocele. So This is how you read a CT scan. So you have to plan. I will plan for a left Hadad flap, and then I will be doing a sphenoidotomy, posterior ethmoidotomy, and I will be repairing the defect. I particularly put up this scan because the pathology was in the last two cuts. Hence, we will train your eye to see only the anatomy first. And this is the part 1 of reading a CT scan. Train your eye to read the anatomy, anatomy, and anatomy. In part 2 of reading scans, we will see how we can three-dimensionally reconstruct the 2D scan into a 3D. I call it the Z factor in reading the CT scan, and we will meet in the next classroom. Hope this was useful to you, and we will see in CTPNS part 2. Thank you very much.